There are several objectives to this segment. First, we want to talk about the natural history of Alzheimer's disease. Next, we want to describe common cognitive and psychiatric symptoms associated with patients in the latter stages of the disease. Next, we want to explain management strategies of common problems such as weight loss, pain, and falls in the end-stage dementia patient. We want to describe legal decisions for terminal care of these individuals. And finally, we want to go over the spiritual needs of both the patient and the caregiver. Let's begin by reviewing the disease. We know that Alzheimer's disease is the progressive loss of neurons. And in this graphic, we see a brain on the left, which has mild dementia, a brain in the middle from a patient with moderate, and a brain on the right, which has severe dementia. And you don't need to be a neuropathologist to see that over the course of this illness, there has been substantial loss of brain tissue. As the tissue is lost, function is lost as well. The natural history of dementia is that the average patient lives for about 8 to 10 years. Now, there's a broad range with this. Some patients live as short as a few years, and other patients can live for 20 years. Staging systems vary from 3 to 7 different stages. I like the simpler staging system, which is a 3-step system: mild, moderate, and severe. Today, we're going to be talking about patients with severe end-stage dementia. We know from studies that the rate of progression in patients with Alzheimer's disease is that they lose about 2 points from their mini-mental per year. Any loss greater than that should suggest some other process going on, such as delirium or medical problems. Unfortunately, there is no real way to determine who might lose the points on their intellectual rating faster and who might lose them a little bit slower. We also know that patients in the end stage with severe dementia have a high risk for institutionalization, with only about 16% being institutionalized who are mildly demented versus over 3/4 being institutionalized with severe dementia. Most of that institutionalization is in the setting of nursing homes. What are some predictors for institutionalization? Well, first of all, if there's no family caregiver, if there's not a caregiver support network, that patient is more likely to wind up in a nursing home early. Secondly, family caregivers struggle with incontinence of bowel and bladder. And third, those individuals with severe behavioral problems oftentimes wind up in nursing homes sooner. Obviously, anything that can be done to prolong continence or to lessen the impact of behavioral problems will lengthen the duration of time that a patient can remain outside the institution. What are some of the typical cognitive or intellectual manifestations of end-stage dementia? Well, let's go back to the 4 A's that we've talked about in earlier segments and add a couple more A's. Amnesia, aphasia, apraxia, and agnosia. You're well familiar with the 4 A's. But in addition to that, we're going to talk about anorexia and amotivational states in the end-stage dementia patient. Let's begin with amnesia. What happens in the end-stage patient is that they have almost total loss of recent memory and fragmented remote memories. As the disease progresses, these fragmented remote memories can be fused into stories that patients seem to make up. They may start off telling you about a family picnic and wind up telling you about something that happened at their son's graduation from college, and the story tends to run together. We know, for instance, in this picture, that the temporal lobe, as outlined here by the arrow, undergoes severe shrinkage and atrophy in the latter stages of the disease, as seen here on the right side in the late stage. That's why memory is severely and consistently affected in late-stage Alzheimer patients. In addition to the memory problems, patients also develop severe language problems as the disease progresses. They get both receptive and expressive aphasia. In the latter stages of the disease, they have minimum understanding of written or spoken word. They may have some comprehension of nonverbal communication, such as a smile or a gentle touch. They have tremendous difficulties on the expressive side. They oftentimes speak with simple words, short phrases. Oftentimes they perseverate. They keep repeating the same word or phrase over and over again. And eventually, as the disease progresses, they may actually just simply grunt or curse. Remember, you speak off the left side and curse off the right side of your brain. Simply because an end-stage patient can still curse doesn't mean that they can still speak. What's going on in their brain, as we see in the next graphic, on the left is a temporal lobe where receptive language skills are programmed. In the middle is a mid-stage Alzheimer patient, and on the right is an end-stage Alzheimer patient. And you can see from the left to the right that there is severe damage to the part of the brain that interprets spoken word. Most patients with end-stage Alzheimer's disease develop severe receptive aphasia. As we spoke about in earlier segments, the part of their brain that does the hearing is not affected by the disease except in the very late stages. Consequently, the patients may still be able to hear and respond to auditory stimuli, yet they will not understand what is being said to them. Moving on through the 4 A's, which have now become the 6 A's, we move on to apraxia. Typically in end-stage Alzheimer patients, there are severe impairments of activities of daily living. Oftentimes, they're no longer able to shave, bathe, brush their teeth. In addition to that, patients begin to forget how to walk. That's referred to as a gait apraxia. What happens is the patients, when you stand them up, don't seem to know what to do with their feet underneath them, and they sort of have a stiff-legged gait. This predisposes these individuals to falling. Patients also forget how to chew and swallow, and we're going to talk about that later on in the nutrition and the feeding segment to this program. What's going on is that the parietal lobes of these individuals and the frontal lobes, which program many of these sophisticated motor functions, are being erased by the disease. On the left, a mild dementia patient. On the right, a coronal section from a severely demented patient. And as I said before, you don't need to be a neuropathologist to appreciate the severity of brain shrinkage. Finally, there's agnosia, inability to recognize previously learned sensory inputs. Oftentimes, these patients develop agnosias across sensory modalities. What that means is that, for instance, the patient may develop a visual agnosia where they can no longer recognize their own image in the mirror. They may develop tactile agnosias where they don't recognize the feel of things. And even they may develop what I refer to as visceral agnosias, where they're no longer able to fully interpret internal sensations. This failure to interpret sensory information is very important. They may misidentify family caregivers. They may not know the touch of a utensil like a fork or a spoon. And they may not be able to distinguish between a full bladder and a full colon, so they won't know whether or not they need to pass water or have a bowel movement, or whether they're having severe pain from a ruptured diverticulum. All of these things complicate management of these patients. What's causing that is severe damage to the sensory association cortices. That is, the parts of the brain that interpret sophisticated sensory information. In this slide, we see 3 levels of occipital lobe. On the left, from a mildly demented patient, in the middle, from a moderate, and on the right, from a severely demented patient. The occipital lobe interprets visual information. Therefore, the patient on the right side may not have been able to recognize their family caregiver's visual impression anymore, nor they may not have been able to understand their own face when they saw it in the mirror. By the way, in end-stage dementia patients, if they do not recognize family caregivers or home health aides anymore for who they are, they then conclude that whoever is in the house is a stranger, which can therefore lead to some behavioral problems. That's one of the reasons you should never keep weapons in the house with an advanced Alzheimer patient. Remember, they may not recognize who you are anymore, and they could potentially attempt to harm you. In addition to the 4 A's, amnesia, aphasia, apraxia, and agnosia, end-stage patients develop somewhat of what's referred to as an amotivational state. What that means is that they develop what some persons refer to as a frontal lobe syndrome. What are your frontal lobes? They're the parts of your brain that are your intellectual and emotional spark plugs. They get you going in the morning. They help you get organized and function properly. If I damage that part of your brain, then you become apathetic. You don't care anymore. You'll just simply sit there. Even though you know you may need to go to the bathroom, you simply won't get up because your frontal lobes aren't there to tell you to get up and get going. In the next slide, we see what frontal lobes look like from an early versus mid versus late stage Alzheimer patient. And as you can see on the right, there is conspicuous loss of brain tissue in the frontal lobe of an individual with Alzheimer's disease. This patient may develop apathy, where they simply don't care about things anymore. It's not necessarily a representation of laziness or some sort of spiritual loss. It's simply that their intellectual and emotional spark plug has been quieted by the disease. In addition to the 6 A's, amnesia, aphasia, apraxia, agnosia, amotivational state, and anorexia, and we're going to talk about loss of appetite later on in this segment, patients also develop psychiatric complications. Patients may develop hallucinations. Oftentimes the hallucinations occur in the mid-stage of the disease, but usually they persist through the latter stages of the disease. The patients may develop delusions, false beliefs. They may think that they're being stolen from, or that they're being abused, or that their caregiver is trying to hurt them. Oftentimes these patients have difficulty explaining why they are distressed because their language centers have been destroyed, even though they have these false beliefs. And end-stage patients, because of damage to the brainstem, may also develop depression, even if they never had depression in the earlier stages of the disease. Any time an Alzheimer patient in the latter stages of dementia will no longer get up and go around, will no longer eat or feed, whenever they have a precipitous drop in their level of function, they should be assessed to determine whether they may be developing depression as an end-stage manifestation of this disease. Hallucinations, delusions, and depression. These are common psychiatric complications in the patients with end-stage dementia. In addition to that, in the latter stages of the disease, patients also develop multiple behavioral complications. As I said before, patients forget what a full bladder or a full colon means, and then they become incontinent. And because they can't tell you anymore, and they can't remember where the bathroom is, they lose control of their bowel and their bladder. These patients oftentimes begin to wander, and because they have forgotten how to do their ADLs, they may become resistive. These symptoms are discussed elsewhere in other tapes with regards to behavioral management strategies for wandering and resistive behaviors. In any case, most patients in the latter stages of dementia develop some form of behavioral complication that presents an additional burden to the caregiver. In addition to the intellectual and psychiatric complications associated with end-stage dementia, these individuals also develop medical complications. And we're going to talk about a few of these. We're going to talk about dehydration and malnutrition. Fecal obstipation means that your colon becomes distended with feces. Advanced stage Alzheimer patients have multiple reasons why their bowel does not work properly. First, they are on multiple medications that may slow the emptying of the bowel. Secondly, they're not getting a lot of fluid and a lot of exercise, which help with regular bowel movements. And thirdly, in the latter stages of the disease, as they have to move to chopped or pureed diets, oftentimes the amount of fiber in their diet goes down. As a result, these patients oftentimes develop impaction or simply fecal obstipation. And this can lead to significant behavioral problems as well as refusal to eat. Finally, those patients with advanced gait apraxias, that is, individuals who forget how to walk, even though they can still move their legs and they can still kick and roll their leg over the side of the bed, but they may not remember how to walk anymore. These patients oftentimes become bedbound, and as a result they are at risk for developing decubiti. An aggressive, effective turning program for most Alzheimer's patients will limit or eliminate the risk for decubiti. What are some common causes of death in patients with dementia? Infections is probably the #1 cause. And when we're talking about infections, we're talking about pneumonia, and urosepsis. Urosepsis is blood-borne infection originating from the bladder. Patients with Alzheimer's disease oftentimes don't empty their bladder properly, and women with Alzheimer's disease, because they have a short urethra and less protection against the backwash of bacteria up into the bladder, as well as their loss of personal hygiene, sets women up particularly for developing bladder infections. Because Alzheimer patients can't tell you when it's burning or stinging when they pass water, the urinary tract infections oftentimes go unnoticed, and as a result, they become so severe that they seed to the bloodstream, and this produces urosepsis and death. Likewise, some patients require Foley catheterization, that is, tubes placed into their bladder to drain the bladder, and that as well can lead to urosepsis. Many Alzheimer patients also have cardiovascular disease, anywhere between 20 and 30%, and consequently they may have death by heart attack or other type of cardiovascular event. And many just develop diseases in multiple organs, kidney and liver failure, and as a result they succumb to multiple causes. This then raises the interesting issue, is antibiotic therapy effective in older, advanced stage Alzheimer patients with fever? And it turns out that studies that are published indicate that in patients who are moderately demented, antibiotic therapy may prolong survival of this individual. However, severe, profoundly demented patients, antibiotic therapy probably has no impact in the long-term outcome. This is very important for families trying to determine whether or not they want to place another IV in their patient and then perhaps have to restrain that patient to keep them from pulling the IV out. What are some predictors of brief survival for Alzheimer patients? Well, those individuals who are severely aphasic and those individuals who have repeated infections are at high risk for a rapid demise. Why is that? Well, it turns out that the nerve cells that drive language, spoken language, are also the same nerve cells that probably control our ability to chew and swallow. And severe aphasia means probably that these patients are having trouble controlling their tongue, their mouth, and their chewing apparatus, and as a result, these individuals are at high risk for aspiration pneumonia, which then leads to the repeated infections. Consequently, that severely demented patient who's totally aphasic and who's required antibiotics on several occasions probably is not going to have a prolonged survival. In fact, when you look at published predictors of 6-month survival, and of course for hospice care that's very important, the older you are with dementia, the less likely you are to survive for 6 months, especially with severe dementia. In those individuals with no code status, that is that the family and or the patient have decided that they do not want to be resuscitated. It is possible, by the way, to reasonably reliably predict who will survive for 6 months with dementia. And that's very important in determining their eligibility for hospice care. Now, let's talk about some common medical problems that the clinician and the family or the nurse has to deal with in an Alzheimer patient. And the first, when you're talking about end-of-life care, is effective management of chronic pain in dementia patients. Do Alzheimer patients have pain? Yes, they do. How commonly do patients complain of pain, for instance, those residing in nursing homes? And why are we talking about nursing homes? Because that's where many late-stage Alzheimer patients reside. Well, if you look at the statistic, and this is based on a published study, 3/4 of dementia patients, as well as over half of intellectually intact patients, will complain of chronic pain. On the other hand, if you look at those individuals who are complaining of pain, for instance, in a study that looked at 26% of residents who had chronic and persistent complaints of pain, only up to 1/4 of them were receiving no analgesics. And it turned out that most of those individuals were people with dementia or other forms of Alzheimer's disease. Why is it that patients with Alzheimer's disease don't get adequate pain management? Well, first of all, it's under-recognized. These patients oftentimes have difficulty explaining to nursing staff exactly what's going on. They have both receptive and expressive aphasia, so they don't understand when the nurse asks them if they've got pain, and it's hard for them to tell them that they're experiencing pain. Moreover, because the patients have amnesia, they forget that the night before that they had had a lot of pain with their hip or had had a lot of angina. And in addition to that, doctors and nurses are concerned about delirium, and consequently they're a little hesitant to put patients on narcotics for fear that they might cause them to become confused and develop behavioral problems. But let's look at something simple like the prescription of Tylenol in nursing home residents. Studies show that 21% of patients in nursing homes who are able to communicate will get Tylenol, as opposed to 4% of individuals who are not able to communicate. Yet the studies will clearly show that those non-communicative individuals need the Tylenol as much as the communicative individuals. Consequently, even with the simple, safe, effective forms of therapy like Tylenol, it's clear that we undertreat pain in patients with Alzheimer's disease. So what should be the management of chronic pain in patients with dementia? Well, first of all, start off with non-narcotics. And don't make it on a PRN basis. Why? Because a demented patient is not able to ask for the PRN medicine. What we recommend is if you think that a patient, for instance, is agitated as a result of chronic pain, just give them a couple of Tylenol 4 times a day for a couple weeks and see if the patient seems to be better. If they are better, then go ahead and put them on a standing dose of Tylenol, or you could also use a non-steroidal anti-inflammatory. But be sure you monitor for GI pain in those individuals. The next thing is, don't forget, Alzheimer patients, especially those with contractures, may benefit from physical therapy. We want to distract Alzheimer patients just like we do non-demented patients, so therefore, regardless of their level of activity, we should program some kind of activity. Nothing is worse for pain than sitting in a quiet room by yourself. Even a little bit of music to a severely aphasic, amnestic patient may be a welcome distraction from their discomfort. Some patients benefit from antidepressants. You can go with narcotic analgesics. And if all else fails and you think that it may benefit, don't be afraid to refer a demented patient to a pain specialist to see if there are other things that can be done, such as nerve blocks. There are things to be done about management of chronic pain in the Alzheimer patient. Remember, if that patient was experiencing a lot of pain prior to the onset of their dementia, whether it be angina from heart disease or arthritic pain from degenerative joint disease, they are going to continue to experience that pain regardless of whether they can explain it to you or not. Next, let's talk about falls. Falls are a common problem in older individuals, especially in the Alzheimer patients. We know that based on studies that about 5% of community-dwelling elders are going to have a serious fall. That means they're going to have medical attention for it each year. 1% are going to break bones each year. Remember that some hip fractures, especially for patients who are bedbound, can occur with minimal or no trauma. Simply turning an individual as you stand them up can produce a fracture of the hip of the femur. And as many as 40 to 60% of Alzheimer patients fall in nursing homes. One study shows in a very, very good dementia-specific nursing home that 25% of Alzheimer patients fell within the first 2 weeks that they were admitted to the nursing home, and 75% fell within the first year. So falls are common in the elderly, especially in patients with dementia. Who's at risk for falling? Older people with a past history of falling, who are receiving more psychotropic medications, especially benzodiazepines like Ativan and Xanax, and antipsychotic medications such as Haldol and Risperidone. Individuals with confusion or dementia are at high risk for falls. In any patient who's had a recent weight loss, this usually indicates that they're physically debilitated. They're at higher risk for falls. What should your fall protection program include, especially for a dementia patient? Well, first of all, even if the patient is demented and they seem to have trouble with their gait and they seem to be at risk for falls, a good old-fashioned physical therapy assessment may be helpful. If the patient is intellectually intact enough to use a cane or a walker and they are not behaviorally disturbed such that they might use it as a weapon, then a cane or a walker or a platform walker may be beneficial. In those individuals for whom a cane or walker is not practical but who are still up and ambulatory, a merry walker may be beneficial for those individuals. And don't forget, if the patient is falling, it may be because they don't see and hear well. So always check their hearing and their vision. Other things can also be tried, especially in gait apractic patients who, when you stand them up, can't seem to carry their own weight. Things like low beds with pads on the floors, as well as beanbag chairs, so long as the patient is able to roll out of the chair and get down when they want to. All of those things can help the patient to be comfortable and yet minimize the potential for falls and fractures in these individuals. Next, let's move on to weight loss. And again, we're going through common problems that you encounter in end stages of dementia. We know that patients in the early stages of dementia lose weight from anxiety and depression. However, patients in the early stages should not have serious weight loss unless something else is going on. In the middle stages of the disease, patients oftentimes become resistive to feeding. They have food preference. They may become psychotic and believe that the food is poisoned. They may be depressed and not be interested in eating anymore. They may be agitated, especially those who sundown late in the afternoon and won't eat their dinner. All of these things need to be looked into and appropriately treated. However, in the latter stages of the disease, patients oftentimes lose weight because their feeding and swallowing mechanisms are no longer functioning properly. What are some ways to measure nutritional loss in Alzheimer patients? Well, of course, the first and most obvious is body weight. When you're weighing Alzheimer patients, make sure that the clothing is fairly consistent, that you weigh them on the same scale, pretty much at the same time of day, and under the same conditions. There's a lot of variation in body weights for Alzheimer patients. In addition to that, if you want to do a chemical test to determine their nutritional status, we recommend both the albumin and the pre-albumin as helpful measures for nutritional status, especially if a patient has gone to the hospital, come back to your nursing home, and now they seem to have lost some weight. The two tests that we recommend then are the pre-albumin, which is a measure of short-term nutrition. The half-life of this protein is about 2 or 3 days, so it replenishes itself fairly rapidly. We know from studies that for inpatients that low pre-albumins predict extended hospitalizations. And remember, there are some things that affect the pre-albumin level, such as steroid therapy. A more standardized test, though, is albumin, and this reflects long-term nutrition. This protein has a half-life of about 3 weeks. We know from inpatient studies that low albumin predicts high hospital mortalities. You have to be aware of the fact that patients' hydration and inflammatory diseases may affect the albumin levels. If a patient has both low weight, low pre-albumin, and low albumin, that's a strong indicator that this patient is substantially nutritionally depleted. What are some possible interventions once you've decided that this patient is nutritionally depleted? Well, first of all, look at their diet. It may be that the patient can no longer take a chopped or a regular diet, and now they need a blended or pureed diet. It may be that the patient now needs to be fed. All of these things need to be taken into account. Some individuals attempt syringe feeding with patients, and sometimes this works. However, you have to be very careful because if you syringe feed a patient, you're at somewhat higher risk for producing aspiration pneumonia. We're going to talk a little bit more, though, about feeding tubes, peg tubes, and finally hospice care as an intervention for patients who are losing weight. What are some of the end-of-life nutritional problems that you can encounter? Well, first of all, remember earlier in the segment we were talking about severe frontal lobe damage? These patients become apathetic. they don't care whether they eat or not. It makes no difference to them. Because the frontal lobes also control impulse control, they can sometimes become impulsive, hostile, and resistive during the feeding process. Impulsivity and resistiveness can be treated with medications such as Depakote or antipsychotic medications. The next thing the patient may develop is a feeding apraxia. Feeding is a learned motor task. If you think back to raising children, for those of you who have raised children, we remember that children begin as infants only able to suck from a bottle, and then they begin to be able to take small spoonfuls of very, very basic kind of blended pureed materials. Then they begin to learn to drink from a cup. Then we gradually move them up to the different kinds of food for gradually increasing consistency, being careful with these babies to make sure that as we're moving up, that they don't choke or what we refer to as aspirate. Eventually, they develop full table manners. They're able to sit at the table and conduct themselves normally. They remember what the spoon is for and what the fork is for. Those are the highest order feeding skills. What happens with the Alzheimer patients is, first they lose their table manners. Then they begin to sort of pick food up. Sometimes they'll eat other people's food. Then they become clumsy with their cup and their utensils. Then they need to be fed. As this process moves on, they develop what I refer to as chewing and swallowing apraxias. Just like a small baby who has not learned how to chew and consume a food, these patients may overmasticate, in other words, overchew, or underchew and try to swallow large blocks of food, causing choking and aspiration. This is called chewing and swallowing apraxia. Eventually, these patients forget how to chew and swallow altogether. That's that elderly individual who you've been feeding them and they've taken about 3 mouthfuls, and you think you're really making progress with them because they've got 3 mouthfuls in, and all of a sudden they open up their mouth and out plops the food. What's happened is that patient has forgotten what to do with the food once he gets it onto his tongue. That's referred to as a swallowing apraxia. At this point, the patient is at significant risk for aspiration pneumonia. Which then leads to the idea that perhaps we ought to be putting PEG tubes or percutaneous endoscopic gastrostomy tubes in these individuals. PEG tubes have become a common surgical intervention in patients with advanced stage Alzheimer's disease. I refer to this as the field of dreams. If you look at statistics on patients with Alzheimer's disease, in 1989, Medicare paid for 15,000 PEG tubes. In 1995, it paid for 123,000 PEG tubes. And this is for individuals over the age of 65. What is a PEG tube? When we're talking about doing this procedure to patients, oftentimes it's explained as sort of this small, simple little tube that's threaded through the front of the abdominal wall, through the abdominal cavity, and into the stomach so that the patient can eat without having to chew or swallow. Well, here's a picture of an individual at autopsy with a PEG tube. And you can see here by the arrow, this is the tube entering the abdominal wall. And this arrow here points to the rib cage. So you can see that, first of all, these are fairly sizable surgical interventions. This patient had to be significantly sedated to place this tube through the abdominal wall. And in the next slide, you can see the tube as it enters the stomach, which has been opened up. And then you can see the opening bore of the tube as it enters the gastric cavity. Obviously, if the patient pulls this tube out, then it has to be reinserted if the tract remains intact. If it doesn't remain intact, then the procedure has to be repeated. Why do PEG tubes get placed in patients with advanced stage Alzheimer's disease? Well, oftentimes there's this what I refer to as momentum of inevitability, that there's this constant pressure on the family who's making the decision that somehow this is the right thing to do for this person. Oftentimes, the discussion of risk factors is focused on the procedure and not on the potential complications for the patient. For instance, if the patient pulls the PEG tube out, it's going to have to be reinserted. If the patient continues to pull the PEG tube out, then they're going to have to look at sedation or some sort of restraint to prevent the PEG tube from being repeatedly taken out. Thirdly, there's relatively poor patient selection based on research, and I'm going to talk a little bit about what we know based on the research in just a second with regards to the outcomes from PEG tubes. And fourthly, oftentimes the families don't understand the overall prognosis. In point of fact, if a patient is so severely demented that they can no longer chew or swallow, that they can no longer adequately consume food, then the likelihood is that they are no longer able to also clear their own secretions, which are being continuously produced in their mouth. If the patient is not able to clear their own secretions, that means that they're going to be inhaling these highly infectious materials, which means that they're going to be predisposed to repeated bouts of aspiration pneumonia and all the problems associated with repeated bouts of aspiration pneumonia. If we look at the literature on alternatives explained to families with regards to PEG tubes, based on this one study from 1999, that in many instances, in a patient who is unable to chew and swallow sufficient nutrition to maintain their body weight, in almost half the cases, no alternative was discussed with the family aside from the PEG tube. About 10 to 15% had a nasogastric tube discussed. About 10% had IV fluids discussed, and only 2% had spoon feeding discussed with the family. When in point of fact, slow, steady, small, repeated spoon feedings may well have been able to maintain sufficient nutrition in the patient to prevent aspiration while at the same time maintaining comfort in this individual. What are the family issues surrounding the insertion of PEG tubes? What are some of the things that I've heard families say to me? First of all, they'll say to me, "Doctor, I can't let my mother starve to death." The fallacy of that is in the misunderstanding with regards to the dying process in an individual no longer able to chew and swallow. The next thing families will say to me is, "Doctor, I can't let them die." Well, in point of fact, there's nothing you can do about this. As we've shown you in all of these pictures of dying brains, these individuals are going to die regardless of whether we put PEG tubes in them or not. And finally and commonly, the families will say to me, "I just simply can't make this decision. It's too hard, doctor." That's why clarifying advanced directives and patients' wishes early in the disease is so much better, both for the patient and for the families. With regards to, "Doctor, I can't let my mother die like this," it's important to point out that the scientific research indicates that half of patients who have PEG tubes inserted are going to die within 6 months. Not only that, but there's little evidence that in PEG tubes, in dementia, that the PEG tubes actually help. There's no studies, for instance, none, and this is based on the most recent literature, that PEG tubes increase patient comfort. There's no real hard studies that as a group it substantially improves nutritional status. And there's no real hard data in large numbers of Alzheimer's patients that it lengthens survival. Now, there are some patients who seem to be drifting off and you put a PEG tube in and then they linger for an additional year or 2 years or sometimes 5 years. Every physician remembers those kinds of stories. But if you look at large cohorts of patients, the overall impression is no increased comfort, no increased nutrition, and no lengthening of survival. So in conclusion then, when we're thinking about swallowing problems, when that Alzheimer's patient is beginning to choke during feeding, when that patient will refuse to swallow, we've got to remember that this is common, that it's unavoidable. It had nothing to do with the care of that patient prior to the onset of the swallowing apraxia, and it's fatal. Eventually, these patients are going to succumb to aspiration pneumonia. This then brings us to the legal care aspect of our discussion today. There are 3 stages of this disease, and each of the 3 stages requires a different legal perspective. In the early stages of dementia, the family and the patient should record advance directives, and I'm going to talk a little bit about what the advance directives should be. They should identify the decision maker within the family. Who's going to make decisions for mother? And they need to consolidate all legal and financial information in one place so that it's available to everybody. I can't emphasize how important it is to ask the patient about whether or not they want to be put on a breathing machine, life support, or have PEG tubes inserted in them in the event that they are so severely sick that they can no longer maintain these functions for themselves. The vast majority of patients, of older individuals, will tell you, look, you know, if I'm not going to get any better, if I'm that sick that I can't do these things for myself, then I don't want all these tubes and whatnot. What I want is I want to be at home, looking out on my garden, close to my family. This is a tremendous burden that can be lifted from the shoulders of the family if they know that they are carrying out the advance directive of the patient. In the middle stages of the disease, the number 1 legal goal is to protect the patient and the family. At this point, unfortunately, you have to have limited privileges such as driving, executing legal documents for themselves. We now know, based on research, that when individuals' mini-mental status examinations scores drop below 15, they lack the capacity to give informed consent for both legal and financial issues. And although the mini-mental is not an absolute test for this, it is a good roadmap to determine when the patient is no longer able to make informed decisions for themselves. In the late stages, the legal aspects of care should focus on assurance of compliance with patient advance directives. If a patient has an advance directive, neither the family nor the physician should attempt to break that directive unless that there are compelling reasons. And really, that should be adjudicated in court. We want to safeguard the patient's rights. If the patient has spoken for themselves, we should adhere to their wishes. On the other hand, if the patient said to the family, I want everything done for me, don't spare anything, then we should follow that wish as well. When we're talking about advance directives, what sort of issues are we looking at? Well, first of all, we're talking about code status. Does the patient want to be resuscitated? We're talking about feeding tubes, and we're even talking about hospitalization status. At some point, families may say, look, every time he goes to the hospital, he comes back worse. He comes back with contractures and decubiti. They don't understand my father like they do in the assisted living facility or the home health nurse or in the nursing home. I don't want him going to the hospital anymore. That is in the end stage of the disease, that is a reasonable decision for the family to make. And likewise, the decision to commit to hospice care is a reasonable and prudent step in the last stages of the disease. When we're talking about advance directives for Alzheimer's patients, however, it's clear that many times patients have not straightened out these details prior to becoming so demented that they can't speak for themselves. In this one study of Alzheimer's patients, only 1/3 had a durable power of attorney, a very important legal document in medical decision-making, and only 40% had a living will. 52% had basically no documentation on what they wanted and who was to make decisions for them. On the other hand, if you talk to spouses about what they want for the Alzheimer's patients, over half will tell you that they do not want resuscitation. Most will tell you that they do not want the individual placed on a ventilator, and almost a half will say that they're opposed to feeding tubes. Almost a quarter will tell you that really they're not in favor of what would be termed aggressive medical therapy, putting them in the hospital, putting them in the ICU, that sort of thing, but opposed to more passive therapy such as IV antibiotics in the nursing home. Well, what are some obstacles to obtaining a DNR status, do not resuscitate, in an Alzheimer's patient? Well, first of all, there's the family misperception. Oftentimes, families have this failed understanding of what a resuscitation is. We all watch television, shows like ER, where every time a person is wheeled into the hospital in full, quotes, code status, all of a sudden these Hollywood stars come flying out of doors and hop all over the patients and resuscitate them. I refer to this as the Lazarus syndrome, where everybody expects folks to get up off their gurney and walk. Oftentimes, families don't understand what a patient goes through during resuscitation, and they don't understand how poor the outcome is from resuscitation. Then the next thing, of course, is legal consent and family dynamics. If there are not advanced directives, and if the family is in dispute over whether or not to resuscitate the patient or not, the fact of the matter is that the physicians are going to do everything for that patient. We have a general rule in our practice that when in doubt, code them out. And most physicians feel that way. If there's any question at all about what the patient or the family wants for this individual, or if there is any strife within the family over that decision, the likelihood is that the patient is going to get resuscitated. What is the aftermath of poor planning for these individuals? Well, it's multi-leveled. Well, first of all, the patient in a situation where there's no advanced planning is excluded from the discussion. It's good to ask a patient while they're still intellectually intact, do you want us to put you on these machines? Do you want these things done to you? In addition to that, once they start, it's very difficult to stop. Once the patient gets intubated, then they want to put a pacemaker in. One thing leads to another, and you wind up getting multiple unnecessary procedures. And then you have all the complications from the procedure. You put a PEG tube in a patient, and then they get an infection from the PEG tube. In addition to that, not all of these expenses are reimbursed, and the family and the estate accumulates additional expenses that the patient may never have wanted. But most importantly, for those individuals who didn't want all of these invasive procedures done, it prolongs their suffering, the family suffering, and enhances the family guilt over discontinuation of the machines once the decision is made that we're not going to be able to save Dad. He's just clinging to the breathing machine, to the ventilator, so therefore we have to take him off the ventilator. Believe me, it's far more difficult to take a person off the ventilator than it is to never put them on the ventilator in the first place. Remember, based on the best literature that I can see, it's my best estimate that the success rate for resuscitation in individuals over the age of 70 with dementia is about 3%. That means that the vast majority of patients whom you attempt to resuscitate are never going to make it out of the hospital and resume any sort of meaningful life. The reality is that once the patient becomes that desperately ill that they need to be resuscitated, their fate is sealed anyways, and in most instances, you're simply prolonging the suffering and the agony of that patient. What are some indications for hospice care then? If you don't want to resuscitate a patient and you don't want to put a PEG tube in them, what are some indications? When can we say that a patient should qualify for hospice care? When are they within 6 months of their life? Well, first of all, if they have a DNR status. It would, of course, be counterintuitive to put a patient in hospice and then have them be a full code. The patient should have advanced dementia. Mild to moderately demented patients may benefit from PEG tubes. They may benefit from resuscitation, although even mildly demented patients, when they are resuscitated, oftentimes have a dramatic drop in their function. Patients who are severely aphasic and have severe swallowing problems, swallowing apraxias, those individuals are probably appropriate for hospice care. Individuals who have recurrent infections. And remember, oftentimes infections can be overlooked. Many times Alzheimer patients do not mount the same kind of febrile response that non-Alzheimer patients mount. Remember that many times Alzheimer patients' basal body temperature, instead of being 98.6, is 98 or 97.8 due to the damage in the hypothalamus. So for those patients, a temperature elevation to 100 may represent a significant febrile response. And when they're having recurrent infections, that is an indication that they are at the end of their life. as well as other fatal diseases. If the patient has cancer or severe end-stage cardiovascular disease, obviously that patient is in the latter stages of their life. Whenever you talk about hospice care, many times families are hesitant to do this because they say, I can't allow my mother to starve. These statements are oftentimes made because oftentimes the families do not understand the effect of starvation in the Alzheimer patient. What happens when a patient is so demented they're no longer able to chew and swallow, and the family has decided to not put a PEG tube, an NG tube, or an IV in them? Well, the first thing that happens is the patient becomes dehydrated. And after 24 or 36 hours, their thirst drive, if it was there in the first place, has been pretty much eliminated. Then, as they become dehydrated, their sodium level goes up, and they are no longer able to excrete blood urea nitrogen, which means that their BUN goes up. As these two indicators go up, the patients drift off into a dreamlike state. They do not appreciate pain. This form of dying in an Alzheimer patient is not painful. Eventually, the kidneys cease to excrete urine. Now, it is important to remember that oftentimes these patients do not die within 24, 36, 72 hours. Oftentimes it can take days or several weeks. However, it's very important to remember at this stage in hospice care, the patients are really in a dreamlike state. And then what you do is just focus on comfort issues. You can provide them with ice chips. You can provide them with small sips of hydration if they want it. If they're able to chew and swallow, then you can provide those things if you so choose. They should be sedated so that they're not agitated. They should receive as much analgesic pain medication as is necessary. But most importantly, in the dying process with an Alzheimer patient, they should have companionship. Most Alzheimer patients should be able to die at home with their family in the care of a hospice team. What about family issues through all of this? Well, we have to remember that in the end stage of an Alzheimer patient, the families are also in the end stage of suffering with this. There's a high degree of stress in the family. There's fear over what's going on. Even though they know it's a fatal disease, there's this fear of the unknown. Alzheimer's disease oftentimes isolates family caregivers, and that adds to their burden. And in addition to that, the families have been experiencing a continuous bereavement. Many caregivers describe Alzheimer's disease as a continuous wake that goes on for years. So they're already in the midst of their bereavement. And in addition to that, they've spent down a large amount of their money trying to care for the Alzheimer patient. So you can see that in the latter stages of the disease, we not only need to take care of the Alzheimer patient, but we also have to take care of the caregiver. Hospice teams are excellent at providing that kind of combined therapy. In conclusion, then, for family impact, that caregiver winds up with both physical and emotional exhaustion that requires support. They have financial exhaustion, for which unfortunately not much can be done. And in addition to that, because these individuals oftentimes withdraw from church activities as a result of their inability to find folks to stay with their patient to attend church, they don't have that spiritual communion with their spiritual community to help sustain them through these difficult times. In this circumstance, the pastor can play an invaluable role in lessening the impact both on the patient and on the family. In conclusion, then, it's very important to remember that in the latter stages of Alzheimer's disease, that these individuals are fundamentally dying from this disorder. We know, based on the pictures that I've shown you and the biology that I've described to you, that their brains are basically dying. And as a result of their brains dying, we know that their mind is being erased. However, their soul is still in there. They are still children of God. They are entitled to be treated with humanity and with the dignity and respect that they deserve as valued members of our community.